Yes, I'm Dr. Masrar, professor at Upper Medical College, Hyderabad, and it is my pleasure to moderate today's scientific session at the 46th Annual International Conference of Pakistan Association of Pathology. We have a series of highly informative talks lined up today. Before we begin, may I request our respected chair, Professor Dr. Samina Zaman, Professor Dr. Stephen Billings to co-chair, and Dr. Anil Parvani on stage. Please, I request Dr. Ijaz to please join on the stage. Thank you. Thank you for joining us on the stage. Our first presentation will be delivered virtually by Dr. Zubair Baloch, Professor of Pathology and Lab Medicine at the University of Pennsylvania. He's the director of the Endocrine Pathology Service. Dr. Baloch is joining us live online, and he'll speak on practicing thyroid pathology in the era of clinical risk stratification. Please welcome Dr. Zubair Baloch on Zoom for his virtual talk. Let's start our event with the name of
If you start
Allah.
you can call zero.
I welcome Mr. Abdul Salam for Tilawat.
You know how to select that and how to build it up. What steps are you going to do? I mean, for someone like me with these big steps.
Please switch up your mics until analysis will allow you. Please requested to switch off your microphones.
All depends on the patient, what he's suffering from.
Bismillahirrahmanirrahim. Qul huwallahu ahad. Allahu samad. Lam yalid wa lam yulad. Wa lam yakul lahu kufuwan ahad. Sadaqallah.
I request Dr. Zubair to please start his virtual talk. Our online participants are requested to keep their mic off. Dr. Zubair, could you hear me? Can you hear me?
Yeah, I can hear you. Can you see my screen?
Well known for its allergen immunotherapy, which is anything but immunotherapy. For those of you from Karachi, you know how this used to be.
Okay, can you guys hear me and see my screen? Just a shout out.
Yes, sir, you are audible.
And can you see my screen?
Yes, sir. Yes, sir.
Okay, great. Thank you so much. So I want to thank you, the Pakistan Association of Pathologists and Dr. Mulazim Bukhari for inviting me to give this talk. For half an hour, I will try to give you my perspective on how endocrine pathology and specifically thyroid pathology has really changed. And I think we are at a very good place where it is aligned with the clinical management of these diseases. And it is also becoming important that less is more. So the way we are treating these patients is very in a very way with not extensive treatment. Not everybody is getting total thyroidectomy or receiving radioactive iodine treatment for the treatment of papillary thyroid carcinoma. So when we talk about the risk stratification, and especially clinical risk stratification, it's very important to understand where we stand nowadays in thyroid pathology. So I think it's important to kind of take a very quick look at the current status. As we know, the thyroid pathology diagnosis starts with biopsy of thyroid nodules. And the most common way a cytopathologist classifies those specimens is based upon the commonly used Bethesda system for reporting thyroid cytology, which is actually in its third edition. And over the years, we have learned how to differentiate between benign versus malignant lesions. And based upon the nuclear features, when they are not benign completely or completely malignant, then we get into this gray zone, or what we call as middle zone, which states from the atypical FNA to a neoplastic FNA and suspicious for malignancy. And this is based upon, we developed this, most of these algorithms are personal because everybody's thresholds are very different. And that's why you will see a lot of observer variability in looking at these very small biopsy specimens. Still in the third edition, what has been brought up, it's actually with the times. In US and a lot of European countries and also in Asian countries, some of these FNAs do undergo molecular testing, and that's why molecular testing is part of the usual management when you're dealing with a thyroid FNA. This classification also takes into account the tumors that we used to be called as encapsulated follicular variant of papillary carcinomas. Now they are being called as non-invasive follicular tumor with papillary-like nuclei. So these are non-invasive tumors. So this classification also takes that category, what we call as low-risk neoplasms. That means these are going to behave greater than 90+% of them are going to behave in a benign fashion. So that classification also takes that into account, because if you take those malignant cases out, your percentages of malignant tumors is going to drop for each category. Now, this classification also takes into account, which we've not so much practiced before, but we are seeing more and more of this, is pediatric thyroid nodules. So the FNA of the pediatric thyroid nodules, they can also be classified according to the Bethesda system, but their risk of malignancies are a little bit different. Now, when we talk about risk of malignancies, we do have to take into account that cytopathologists are used to that risk of malignancy, and this actually applies not just for thyroid FNAs, but also to many classifications schemes which have been put up by WHO, and these are cytology classification schemes. And now we are working on a WHO version of cytology classification for all head and neck lesions, which will include thyroid, salivary gland, and other head and neck lesions. So that is something to really look for, because it's not a replacement of the existing thyroid FNA classification scheme. This is going to be something which can be used classification for all head and neck FNA cytology, and look at the histologic classification of thyroid neoplasms, which came out in 2022 and was just published by WHO as the 5th edition for neuroendocrine tumors. You realize that the thyroid tumor classification also uses the clinical terminology. It uses the term benign tumors, which we always use as a pathologist, but also uses the term as low-risk neoplasms. And these tumors we know have a very, very low chances of recurrence. And those are the European versions of tumors that they call, which we call sometimes in US as minimally invasive carcinomas. And they call it tumors of uncertain malignant potential. And the non-invasive follicular variant, which is now called as NITP, or non-invasive follicular tumor with papillary-like nuclei. But I think one has to realize that our understanding, and even if you are not a molecular pathologist, and I am not a molecular pathologist by trade, but understanding the molecular profile of a tumor really opens up your mind and how you think about these tumors and how they are going to behave. And I think for the thyroid, the best thing that happened in the tumor classification was the TCGA of looking at basically commonly occurring tumors of thyroid, which were papillary thyroid carcinoma. But if one looks at their graph, they also included tumors which were follicular thyroid carcinomas or follicular adenomas. What it brought to us was that the tumors which have the beautiful nuclear features of papillary cancer that we can see on cytology as well as on histology were tumors that were driven by BRAF V600E mutation. And this is the mutation you see in melanomas, some colon cancers, and also in thyroid cancers and lung cancers. What they also showed that the tumors which were forming only follicles, that means they were follicular pattern, regardless of the nuclear features of papillary cancer or invasion, these encapsulated follicular pattern tumors were driven by RAS. And this really kind of brought up really a good understanding of this tumors, which is the most common being papillary carcinoma. It also brought in an idea of what was called as thyroid differentiation. That means the tumor cells still have a intact sodium iodide supporter mechanism. That means their differentiation is much better than, so their comparison was that the RAS-driven tumors, which are forming follicles, had a higher thyroid differentiation score as compared to the tumors which were driven by BRAF. And I'm going to get back to it in a minute because I think it's very important to understand that. What they thought that the tumors that we call as papillary thyroid carcinomas that form papillae, they are infiltrative tumors and greater nuclear cytology, as I mentioned, were BRAF driven as compared to the tumors which were forming follicles. Now, what we realized that the tumors which are BRAF driven, which is your classic papillary carcinomas or tall cell subtype of papillary carcinomas, these tumors have a they are not sensitive to negative feedback. And because the BRAF and RAS belong to the MAP kinase signaling pathway. In summary, what does that mean? That if you are not, the tumor is not sensitive to the negative feedback from a tumor suppressor mechanisms, these tumors are going to behave in an aggressive fashion and have greater chances of metastasis. And we see lymph node metastases in BRAF-driven tumors as compared to RAS tumors. They only metastasize when they invade into the blood vessels. So this was very important. What it also brought out that the BRAF-driven tumors, which are your classic papillaries or tall cell papillary carcinomas or Wharton-like papillary carcinomas, which were not sensitive to these feedback, responded poorly to radioactive iodine uptake, which is one of the common ways of treating metastatic papillary thyroid carcinomas. So this really kind of aligned that molecular profiling and pathology diagnosis with how these tumors are treated. So my version of looking at this, that when you see on cytology a tumor which has really gorgeous nuclear features of papillary carcinoma, including inclusions, and is forming papillae. And that's what it shows on histology, is a BRAF-driven tumors. But the tumors that we cannot call outright as malignant, and we call them as follicular neoplasm because they're forming follicles, they have monotonous cell population and thick colloid, and these tumors are encapsulated tumors with or without nuclear features of papillary carcinoma. These tumors are RAS-driven, and the most common being NRAS. So even if you're not doing molecular pathology or not a molecular pathologist by trade, understanding these mechanisms really opens up on how these tumors are going to behave. Now, this is what the bottom line was from the WHO 2022 classification. And this paper, which was published by Dr. Kakudo as the senior author, it really showed that when you take that differentiation of a tumor and you look into what will be the possible or by genetic profiling, what will be the molecular signature, you can really put in all those tumors. So you can put in the tumors which are well differentiated, which can be papillary carcinomas. And based upon these BRAF-driven tumors, if you look at the anaplastic thyroid carcinomas, they do arise commonly from tall cell subtypes of papillary carcinomas or classic. But when you go into the route of RAS-like tumors, you have more encapsulated and circumscribed tumors. So it really put in this whole perspective of how we classify thyroid tumors. So now let's break it down by everyday thyroid pathology. When we're looking at a tumor, we're looking at the growth pattern, whether it's papillary or follicular, and whether the tumor is encapsulated. And if it's encapsulated, whether it's invasion or not, because that relates to being called as carcinoma. Microscopic evaluation helps you looking at the nuclei and what type of differentiation that tumor has. Does it have nuclear features of papillary carcinoma? Is it an oncocytic tumor? Or it's just a tumor with follicle formation, or it has squamous differentiation? What is now becoming very important that when we are looking at these tumors, which I don't think we paid too much attention to, is looking at if this tumor has necrosis. And do you identify this tumor necrosis on low power, medium power, or high power? That means, is it focal or a diffuse or multifocal necrosis? And that plays into the diagnosis of high-grade or high-risk tumors. And that's definitely looking at angioinvasion. So the onus lies now on the pathologist that when we are looking at these tumors, we really examine this tumor in detail. We examine the capsule, and our sections should include complete examination of the capsule. You do not have to examine the entire tumor, but at least examine the entire capsule for encapsulated tumor, because that's where you're going to see the invasion. Also, the sections have to be meticulous, because if the tumor is really pressing onto the periphery of the thyroid, there's going to be a lot of artifacts which can mimic vascular invasion. So as you can see here, it will be impossible on this right-hand side to really say whether there is a vessel or not. What also it's important that when you take these sections, the vascular invasion can be very focal phenomena. And that's why the entire examination of the capsule of this tumor is very important. It also breaks the rules that some tumor, which on gross examination can look like cystic nodules, which we always related to when we have a solid or cystic nodule as being a benign nodule. But you can see when you really examine this capsule, and you can see here, there is a focus of vascular invasion where the tumor is sitting in a vessel. So That's why it's really important for the risk stratification that we really do our best to examine these tumors. So now when you put this all together on histology, the tumors that are encapsulated, have minimal invasion, are going to be the low risk tumors as compared to the tumors which have necrosis, solid growth pattern, or which look like anaplastic thyroid carcinomas. Now, when you think about the risk, this risk is actually the risk of recurrence. A lot of patients with papillary carcinomas, up to 99+% do not die of their disease. So this is not something like a lung cancer or a brain carcinoma or high-grade lung carcinomas. So when you combine all this stuff, this is my way of looking at these tumors. The key histopathologic features that we talked about, the diagnosis which range from benign to highly malignant tumors, and then the tumors with no or low risk of recurrence are going to be the follicular adenomas and minimally invasive carcinomas as compared to the tumors that has moderate to high risk of recurrence. And this also plays in with the molecular profile. I was lucky enough to be part of the American Thyroid Association group, which looked at the risk of structural recurrence. And we're talking about local regional recurrence. That means recurrence of tumor post-surgery in the neck. So this is called the risk stratification. And as you can see in this diagram, and this is published online and freely available, just came out a couple of weeks ago, that when you look at the papillary thyroid carcinomas, the tumors which have metastatic lymph nodes, up to 5 lymph nodes, with less than 2 millimeter metastatic foci, because the 2 millimeter is the cutoff between micro and macro metastatic deposits. The tumors, even with micromets, up to 5 lymph nodes and measuring less than 4 centimeters or less, will have a very low risk of tumor recurrence. And in those cases, radioactive iodine may not be necessary. The good follow-up, and these patients definitely do not need total thyroidectomy if the rest of the lobe is normal. And this, as you can see, it goes up. And now when you look at all these factors that play into risk stratification, it's all what we see under the microscope. And this applies same for follicular variant. And we also included follicular variant of papillary thyroid carcinoma in this because these are RAS-driven tumors, encapsulated tumors, and oncocytic carcinoma. So this risk stratification takes into everything that we write in our report. Now I'm going to show you a case very quickly, because to me this is very important that sometimes the majority of the cases do follow the paradigm that we use, the encapsulation, which tumor is going to metastasize, which have the nuclear features. But there's a whole new group of tumors that we are recognizing now. And we are lucky to recognize this because of the molecular profiling. Now, this is actually a 15-year-old euthyroid genetic female who had a 2.7 centimeter left lobe nodule, and the left level 4 in the neck. She also had a cystic mass, which was noted 3 years ago. The clinician said that this is nothing, this is benign, and they gave her some antibiotics. The mass kind of fluctuated, and they said, this is nothing, this is just goiter. But level 4 in the neck, for a goiter to happen, you have to be very careful. And as you can see on ultrasound, this is a very cystic mass lateral to the thyroid hair. And in the thyroid, there is a nodule which is cystic as well as solid. The FNA was done on the level 4 neck mass and had some benign appearing cells, no nuclear features of papillary cancer. And we didn't know at that point that these are cells which are coming from thyroid or some from somewhere else. We always, when we have a neck cyst, we always send a rinse of that portion of that specimen for thyroglobulin assessment, because That's a common site for thyroid tumors to metastasize. Her thyroglobulin was very high, which is very indicative of a neoplastic process. And this is from the neck. So definitely this is indicative of a metastatic process. This was definitely a lymph node. So you can see here are the lymphocytes. And this was her thyroid lesion, which looked very benign. Those of you who do cytology can realize there's a lot of colloid in the background. There are very small, dark follicular cells with no nuclear features of papillary cancer. And then the patient underwent, because of their thyroglobulin level 4 and 6 dissection. This is the lymph nodes. This is actually few of those cases which shows metastatic carcinoma in a macrofollicular growth pattern. And you can imagine if a needle goes in this, it's going to give rise to a lot of colloid and very few cells. And those cells are going to look benign. This is her thyroid nodule, which did not have nuclear features of papillary cancer. And if you can look here, you can see here some samoma bodies, but very macrofollicular growth. And this, on molecular analysis, had DICER1 hotspot mutations. So the DICER1, which we know can be a germline mutation and can be associated with tumors of other organs, including thyroid, usually it gives rise to benign nodules. But in some sporadic cases, when you have these mutations, you can see that these tumors are very macrofollicular. They're encapsulated, very minimally invasive, and these tumors can lead to metastasis. So these are the tumors which are really not following the route that we are used to looking at the tumors as papillary carcinomas or follicular carcinomas. And this has been in the literature. There's a whole group of tumors that give rise to these macrofollicular growth patterns with a lot of colloid, encapsulated tumors, and they can cause metastasis. And these were the DICER1 hotspot mutations. This patient was tested for germline and it was negative. So this is just to show you that even you are not doing molecular pathology, understanding some of these tumors, how they arise, can really make you understand that some of these tumors do not follow the rules. The other thing that I pointed out when we're looking at the microscopic features is to think about tumors which have other features beside nuclear features of papillary cancer or invasion. And what is becoming very common understanding now is, and I really look for it, so this is actually one of the cases of poorly differentiated carcinomas, which we cannot diagnose on FNA, but you can see how these tumors have solid growth and massive amounts of necrosis in them. And it sometimes can be kinetotype necrosis or very blocks of necrosis in these tumors. These do arise in the background of papillary or follicular carcinoma, and this is how the rest of the tumor looked. But here is the necrosis and very solid growth pattern. This was the cytology on this case, and it just looked like your Bethesda 4 or Bethesda 3 nodule. It did not have any other features. But now if you go back and look at this stuff, which is hanging off of this cells, this is actually necrotic debris. So one has to be very sensitive on cytology, even if it's not callable, to just mention that there may be focal necrosis in these lesions, because this is becoming very important for us. Now, when you look at the literature of these papillary thyroid carcinomas, which have beautiful nuclear features, or follicular carcinomas, and then they have necrosis and increased mitosis, or your classic poorly differentiated carcinomas, they all come under the umbrella term of high-grade follicular-derived non-anaplastic carcinomas. These tumors can have lymph node metastases, and rarely, but it does happen, patients can die of these disease. They are in older age group, and they tend to be larger tumors. So this is one of our studies that we published, but then there are now many studies available in the literature. And it really plays into the molecular profile of these tumors. And as you notice, majority of these tumors are going to be BRAF and RAS-driven tumors, and they take on additional mutations or molecular alterations as compared to what you will see in well-differentiated carcinomas. So understanding that little key molecular features will really make you understand how these tumors are going to behave post-operatively. And then now they play in according to the new ATA classification or American Thyroid Association risk stratification classification as low intermediate risk of recurrence and high intermediate risk of recurrence. So the clinicians are really paying attention to these other molecular alteration that we are seeing besides BRAF and RAS, and also whether these tumors have focal invasion, that means focal angioinvasion, that means less than 4 vessels or more than 4, and that has been now proven by many studies. So I think when you're looking at the molecular landscape of thyroid tumors and what you see under the microscope, it kind of reminds me of Dr. Rosai wrote this article on how molecular or the morphology defines the molecular or vice versa. And he wrote that what we see on the slide, the most cheapest version, what we see on the microscope is H&E. And that H&E goes very far. We can really predict how these tumors are going to behave. But adding this molecular stuff helps us to realize how these tumors are going to behave and when you look at how the radioactive iodine refractory, that means these tumors do not respond to the traditional treatments. There are many versions of how these tumors are defined. That means these tumors can be initially radioactive iodine avid. That means they can respond to radioactive iodine, and later on they don't. So there's 4 versions of it on the slide, as I have pointed out, by clinical societies. And this also plays into that thyroid differentiation score we talked about. The papillary infiltrative tumors with lymph node metastasis being not so sensitive to radioactive iodine as compared to the tumors which form follicles. So, and as we know that more and more of these molecular alterations that we see in high-grade carcinomas, poorly differentiated carcinomas, or anaplastic carcinomas also affect the sodium iodide symporter mechanism. That means that's the one that really brings in the iodine into the cell. So if you have a radioactive iodine, but that sodium iodide symporter mechanism is not working, your tumor is not going to respond to this. So this actually, but when you look at these radioactive iodine refractory tumors, these tumors have higher rate of extrathyroidal extension, and they are high-risk histologic subtypes. That means this is tall cell subtype or oncocytic high-grade carcinomas. So this really what we see under the microscope again, really. So this is the way that what these molecular alterations or having a knowledge of it really helps kind of really, I personally think it enhances what we look at or complements what we look at under the microscope for these tumors. But some of these things can be done very simply. And I had this case actually a couple of months ago, 68-year-old with a slowly growing left thyroid neck mass, which was greater than 5 centimeters. It was PET positive, as you can see, it's lit up with PET. So naturally an aggressive tumors. And my FNA looked like squamous cell carcinoma. It had beautiful squamous cells, really keratinized cells in the background. So it looks cancer. Now it is coming from the thyroid, and we know that the tumor that can have such an abrupt squamous differentiation is anaplastic carcinoma because there is no squamous cell carcinoma of the thyroid gland. In older literature, but now we know that all of these are anaplastic thyroid carcinomas. And this was my cell block that I got, and actually I got more of tissue by doing more passes. But by just doing immunohistochemistry for Paxate, and this is monoclonal Paxate, I can tell that this tumor is positive, so it's definitely of thyroid origin, and it's anaplastic carcinoma because it has also P63 and CK56, which is showing me the squamous differentiation or confirming. But I can actually, we have now antibody to BRAF V600E, and I can do this. And this patient was immediately put into the protocol for anti-BRAF therapy, so they can actually treat this patient. And this patient is actually doing much, much better and didn't need a tracheostomy or anything else at this point. So really, by some of these molecular targets are also, you can do immunohistochemistry, and BRAF is the common one that is now can be used in these tumors. So when we put everything together, I think the risk stratification of a thyroid lesions starts with the clinical features and the ultrasound, and then we layer it up with our cytology. And this is where, when you are looking at, and something has the beautiful nuclear features of papillary cancer, it's callable as papillary carcinoma, or looks bad, the case I showed you, like squamous carcinoma, we can do a lot to really set up how this tumor is going to behave and can be appropriately treated. And as I showed you, that all these pathologic features are part of now the thyroid risk stratification, and this also comes in. So I think we are at a very good point of being basically a part of that. Pathologists are always part of the clinical management team, but having this knowledge has really made the clinicians to treat these patients appropriately. So not all thyroid tumors need total thyroidectomy and radioactive iodine treatment. If they are encapsulated tumors, they can just be treated with lobectomy and leave alone. So thank you so much. I hope my message was clear. These virtual meetings are always, there's always problems with the volume and stuff, but I tried my best to just give you a perspective. What is the current status of that is. So thank you so much.
Thank you so
Thank
much,
you so much,
Professor Zubair
Professor
Baloch.
Zubair Baloch.
Are there any
Are there
questions?
any questions?
There are online
There are
participants
online participants as well.
So I thought
I thought
this is all.
this is all.
Oh, thank you,
Oh,
Doctor.
thank you, Doctor.
Just want to say thank you, Dr. Zubair,
Dr.
for
Zubair,
it. It was indeed like just starting. As far as
I'm sorry, I'm having a little hard time understanding. If there was a question, I didn't hear it, but thank you so much for the invite. I really appreciate that. Can you hear me now? I actually cannot hear anybody, so that's my problem.
Assalamualaikum. Itachoe? Or should you? Acho ito may